let's start. First of all, you should know the organs of GIT. What are the organs? You should know, guys. Starting कर रहे हैं हम oral cavity. After oral cavity, we are having salivary glands, right? Salivary glands में क्या पता होना चाहिए बच्चों आपको? There are total 3 salivary glands. What are they? Parotid glands, submandibular glands, and sublingual glands. Okay, parotid, submandibular, and sublingual glands. What does this salivary gland secrete? They secrete saliva, right? The salivary glands are secreting saliva, and in saliva you are going to find 3 important things. What are these? In saliva you are going to find amylase, you are going to find lipase, and you are going to find one more thing, that is a vasodilator. The name of that thing is kallikrein. Kallikrein. Okay. I want to know from you all, guys, what does amylase do, guys? Amylase क्या काम करता है? Amylase is going to metabolize 2 important things, guys. One of them is your carbs, another one is your starch. Okay. Then lipase. Lipase is going to metabolize, of course, lipase, L4 lipase, L4 lipids. And kallikrein, what is kallikrein, guys? Kallikrein is a potent vasodilator. It will help to produce saliva. It will help for what, guys? It is going to help you to produce saliva. Now, after salivary glands, what we are going to have, guys? We are going to have esophagus. Before esophagus, we are going to have pharynx and larynx. Larynx are for respiratory tract. They are not for GIT. Pharynx is important for us. Then the pharynx is going to continue with esophagus. Then esophagus is going to make or going to continue into the stomach. And from stomach, you are having ending of the stomach. You will have one C-shaped organ. And this C-shaped organ is what, guys? The C-shaped organ is your duodenum. Duodenum, important, guys. It is having how many parts? It is having 4 parts: 1, 2, 3, and 4. In between the duodenum, what you are going to find? You are going to find the head of pancreas. Okay. One more thing which you should know, guys. On the which side is this? Right or left? On the left side, no, right. On the right side of the stomach, you are going to find liver as well as your gallbladder. This liver and gallbladder is going to continue one duct, and the name of duct is common bile duct. And this common bile duct is going to attach where? It is going to attach on the D2 part of the duodenum, right? The place where it is attaching, this place is known as what, guys? This place is known as ampulla of Vater. After duodenum, you are going to have jejunum, then ileum, ending part of ileum. This part, guys, is known as what? This part is known as terminal ileum, and terminal ileum is going to continue, is going to convert into your large intestine. Starting part of the large intestine is cecum. Then you are having ascending colon, then you are having transverse colon, and then descending colon. Descending colon is ending into one more part, and this part is what, guys? This part is sigmoid colon, and then you are having rectum and anal canal. What about the layers of GIT, guys? In layers of GIT, we are having mucosa, submucosa, muscularis externa, and adventitia. Mucosa, submucosa, muscularis externa, and adventitia. Right? Important you should know here is what, guys? This adventitia is not present in one structure of your GIT. What is that structure, guys? Anyone who can answer it? It is not present in which structure? It's your esophagus. What is this, guys? It is your esophagus. Great. Now the next thing which you are going to study is what, guys? It is your pharynx. What you should know about pharynx? Pharynx is a funnel shaped organ. It is what, guys? It is funnel shaped organ, right? And this pharynx is the part of both respiratory system as well as your digestive system, or you can say gastrointestinal tract, right? Now, this pharynx is divided into three parts, and we are going to name the parts according to the structure which is present in front of it, right? So the first part is in front of your nasal cavity. That's why we call it what? That's why we call it nasopharynx. Then the second part is front of oral cavity. That's why we are going to call it oropharynx. And the third part, it is in front of your larynx, right? That's why we are going to call it what? We are going to call it laryngopharynx. Another name of this laryngopharynx, as you know, that this is the last part of this pharynx. That's why we call it hypopharynx also. What is the another name? You can write, it is hypopharynx or laryngopharynx, right? Muscles of the pharynx, again very important, guys. So can you see two diagrams, guys? Here this diagram is my lateral view, and this diagram here is my posterior view. On lateral view, if you can see, there are so many muscles. Four muscles are there. Out of them, this green color muscle is what, guys? It is your superior constrictor muscle. Then you are having yellow color muscle, that is stylopharyngeus muscle. Then you are having this orange color muscle, that is middle constrictor muscle. And the last one is what, guys? It is your inferior constrictor muscle. Superior constrictor, stylopharyngeus, middle constrictor, and inferior constrictor muscle. What about the posterior side, guys? On posterior side, few of them are the same, but the one which you are going to remember from posterior side is these two muscle, guys. One is your palatopharyngeus muscle, and another one is salpingopharyngeus muscle. Done, guys? All these are your final exam question, guys. I am going to ask about pharynx, and everything you have to tell me from starting till ending. So pharynx is a funnel shaped organ. It is also respiratory part, as well as it is also in your GIT. Then the muscles of pharynx on lateral side, all these muscles are present. On the posterior side, the important two muscles which I have already told you, it is this. Next important thing which I am going to tell you about this inferior constrictor muscle, guys. In inferior constrictor muscle, we are having two different muscles which you should know. Both of them are very important, guys. Why it is important, we are going to discuss it in few seconds. So first one is what, guys? First one is thyropharyngeus muscle, and another one is what, guys? It is your cricopharyngeus muscle. Thyropharyngeus muscle and cricopharyngeus muscle. Why they both are important, guys? If you will see one video which I have already uploaded, the name of the video is what? The name of video is clinical GIT part 1, right? In this video, you will study about one diverticulum, and the name of the diverticulum is Zenker's diverticulum. That is your FMG exam, guys. FMG exam question. And this you have to see from my previous videos. And please study this video also for your final exam. There are going to be questions from this video also. I have already given you the workbook of this, so you can study this from that video, right? What else you should know? The only first 6 pages from the PDF are important. Not important, like I have uploaded that much only. Whole PDF is important. Later, when we will get time in our summer vacation, I will upload the second part and the third part of clinical GIT also. Now, everyone's favorite topic, everyone know about this thing. That is what, guys? It is your abdominal quadrants. So abdomen is divided into 9 quadrants, right? 1 2 3 4 5 6 7 8 9. All these 9 quadrants are important. I will make you draw these quadrants into your final exams. What you should know, guys? So let's start from top right corner. It is what, guys? It is right hypochondric region. In right hypochondric region, what all organs which you should know, guys. So first of all, I'm having my liver here. Then I'm having my right kidney. My gallbladder is also present here. And some part of my large and small intestine is present, guys. Large and small intestine. What about epigastric region, guys? So the second thing which we are going to discuss it is epigastric region. Why epigastric region, guys? In epigastric region, we are going to have liver, stomach, spleen, duodenum, adrenal glands. Another name of adrenal gland is what, guys? It is known as suprarenal gland because it is present above the kidney, right? And the last one is pancreas. All these things are present in epigastric region. Now we are having left hypochondric region. In left hypochondric region, what all organs are present, guys? So in left hypochondric region, I am having tip of liver, I am having stomach, pancreas, left kidney, spleen, as well as my large and small intestine. That is your upper three quadrants. Let's go in the middle area, guys. In middle area, we are going to call it lumbar regions, right? So I am having right lumbar region and left lumbar region. We are going to discuss first of all right lumbar region. In right lumbar region, what all organs we are having? We are having ascending colon, small intestine, and your right kidney. Okay, guys, that is your right lumbar region. Then this region, you all know that here I am going to have my umbilicus, right? That's why this region is known as umbilical region. In umbilical region, I am going to have duodenum, small intestine, and transverse colon. All these three things are present in my umbilical region. What about left lumbar region, guys? So on left side, I am having left lumbar region. In left lumbar region, what all organs? It is my descending colon. Then I am having small intestine, and I am having my left kidney. Done, guys. Now let's do the last region, and last region is known as what, guys? It is known as iliac region. It is my iliac region, right? On right side, it will be my right iliac region. The organs which are here, it is my appendix, cecum, ascending colon, and small intestine. In hypogastric region, hypo means below, gastric matlab stomach. Below the stomach, what all things I am having? In hypogastric region, the person will have urinary bladder, sigmoid colon, small intestine, and reproductive organs. What about my left iliac region, guys? In left iliac region, you will have your sigmoid colon, you will have descending colon, and small intestine, right? All these things, a patient is coming to you with abdominal pain, you are going to palpate from your hand all these quadrants, and you will ask the patient in which quadrant you are having pain. So every quadrant you are palpating, you have to ask the patient, are you feeling pain or any kind of tenderness in this area or not? If patient is feeling pain or tenderness, means there is something pathological going on among all these organs. So you can divide the organs according to the region. Done, guys? Now, next is what, guys? Next is your esophagus. Again, very important exam question. So, guys, in esophagus, what you have to remember, first of all, the length of the esophagus. So in Viva, what a doctor or what your teacher can ask, in Viva, the teacher can ask how you are going to measure the esophagus. What you should remember, guys, we can measure the esophagus from upper incisor teeth. We are going to start, so we will start our measurement from where? We are going to start our measurement from upper incisor teeth. Then we are having pharynx, and we have already studied that this pharynx is going to convert into the esophagus. Important to know here is what, guys? It is your three different constructions of esophagus. All this important, all these constructions are very important, guys. Out of them, the first one is when it is at the time where your pharynx is converted into esophagus. What is constriction, guys? Constriction means decrease in the diameter of the esophagus. Whatever the normal diameter is there, if my diameter is getting decreased, it is the constriction, right? So in this, what you should know, first of all, we are having this constriction here. This is cricopharyngeal constriction. This cricopharyngeal constriction is present at the level of what, guys? This is present at the level of C6, right? Another name of cricopharyngeal is pharyngeoesophageal constriction. It is also known as pharyngeoesophageal constriction. Then all of us know that just with the esophagus, we are going to have our trachea, and this trachea is going to descend down and bifurcate into two bronchus, the right bronchus and the left bronchus, right? The right one and the left bronchus. The place from where this bifurcation is happening, it is the same place from where your aorta is also going to come, guys. Arc of aorta is going to come at the same place, and it is going to give it three branches. Because of this bifurcation and arc of aorta, they will push the esophagus behind, and now what will happen? The diameter of the esophagus will get decreased. That's why we call it the second constriction. And It is known as what? It is known as, because it is dividing into bronchus. So broncho, it is having arc of aorta. That's a aortic constriction. Broncho aortic constriction. It is present where? It is present at the level of T4. Done. Now the third constriction is at the diaphragm, guys. So all of us know that diaphragm is having esophageal opening, and because of this, the esophagus is going down from the diaphragm. Diaphragm is a musculotendinous structure. It will constrict, right? The muscle have this tendency to get constrict. That's why it is important, guys. Once the diaphragm will get constrict, the diameter of the esophagus will also get decreased, and it will give the third constriction of esophagus, that is known as diaphragmatic constriction. It is the level which is present this, it is either T12 or T11, right? T11 or T12, both are correct answers. Now, if someone is asking you, sir, we know about the according we know about the constriction, but how we will divide our constrictions into parts of esophagus? So from first constriction till second constriction, it is your first part of esophagus. From second constriction till third constriction, it is second part of esophagus, and below the diaphragm, it is what? It is the third part of esophagus. So these parts are known as what, guys? These parts are known as, the first part is known as cervical esophagus, then we are having thoracic, and then abdominal esophagus. What about cervical, guys? So it is starting from T6 and ending where? It is ending till T1 and T2, around 5 centimeter of length. Thoracic esophagus is starting from T1, T2 till T10, T11. It is around 20 centimeters in the length, and it is the longest part, guys. It is the longest part of the esophagus. It is thoracic esophagus, coming from T1, T2 till T10 and T11. Then after diaphragm, everything is known as abdominal. So this is also abdominal esophagus. It is coming out from T10, T11 till T12, and it is coming, and the length of this esophagus is around 2 to 5 centimeters. If someone is asking you what is the total length of the esophagus, what you will say? In boys, it is around 25 centimeters, and in girls, it is around 23 centimeters. Let's see the blood supply also, guys. So this blood supply, all of us know that the blood supply will be either the oxygenated blood and deoxygenated blood. Oxygenated blood from arteries, deoxygenated blood from veins. So the atrial supply of for upper one third part, it is your inferior thyroid artery. For middle one third part, it is the branches which are coming from the descending aorta, and the lower one third part, it is your esophageal artery. This esophageal artery is the branch of left gastric artery. Done. Then we are having the venous drainage. Upper one third is inferior thyroid vein, middle one third is azygous vein, and the lower one third is what, guys? It is your gastric vein. Done. Now we have to study about this vein, guys. It is important. What is the name? The name is azygous vein. Can you see here this green color thing, guys? This green color thing here, it is what? It is your azygous vein, right? What you should know about this, guys? So the azygous vein is going to drain into what, guys? Azygous vein is going to collect the blood from so many veins, and it is going to drain into superior vena cava. It is going to drain where, guys? It is going to drain into superior vena cava. What are the tributaries of azygous vein, and what all veins are coming inside the azygous vein? Let's remember that also. So azygous vein is directly given this deoxygenated blood by the posterior intercostal muscles, as well as on the anterior side it is given this blood by hemiazygous and accessory hemiazygous vein. Then, guys, this azygous or accessory hemiazygous or accessory hemiazygous vein, they both are contributed by what, guys? They both are contributed by anterior intercostal veins as well as subcostal veins. Okay, guys, these two are important. That's how your flow will work. So from the blood, which is the deoxygenated blood, which is coming out from your subcostal vein as well as anterior intercostal vein, it is going to go where? It is going to go into the hemiazygous and accessory hemiazygous, and they will drain into what? They will drain into azygous vein. What about on the posterior side? On posterior side, it is intercostal vein. So it is not muscle, it is intercostal vein. And then it is going to go into azygous vein, and this azygous vein is drain all of your deoxygenated blood into superior vena cava, then into the right atrium, right? That is the concept which you should make. Now, next thing which you should know here is what, guys? It is about the pediatric patient. So suppose you are doing this work, the OPD, you are taking the duty of pediatric OPD or pediatric emergency. There you will see you are going to have some emergency in which you will see that a baby is coming with the parents, and parents are asking that हमारे बेटे ने या हमारी बेटी ने खा लिया है मुंह में, and it got stuck into the, so my baby has eaten something and it got stuck into either in, it can stuck either in your esophagus as well as in your trachea. The concept which I am going to make for you guys is what, guys? So my esophagus is horizontally bigger and my trachea is vertically bigger, right? And the most common thing which these pediatric patients will eat, that is the coin, guys. So all of us know that babies are having this tendency to eat everything, उनको मुंह में लेने की आदत होती है हाँ, they are having this tendency to put everything inside their mouth. So suppose this patient has taken the coins and the coin got stuck either in the esophagus or in trachea. How you will differentiate between these, guys? The main thing which you have to remember is, in this the coin will go front faced like this. So you can see the whole coin from X-ray. We are talking about what? We are talking about esophagus. But it is going into the trachea. How it will go? It will go like this with the sideways, right? It is about trachea. Where we are going to see this thing? We are going to see this thing in your X-rays. So in X-ray we can do two things. Either we can do anterior posterior view, that is AP view, or we can do what? We can do lateral view. Whatever the patient is feeling comfortable into. If patient is comfortable like this, we will do like this. If patient is comfortable, we will do from lateral side. Okay. These are the X-rays which you are going to find. All these four X-rays are your FMG exam question, guys. It has been asked around 7 to 10 times in last 7 years. So from 2020 to 2026, this question has been asked around 5-7 times. What you should remember here, you should remember that if in anterior posterior view, I am seeing only the side face of the coin is in my trachea. But in anterior posterior view, if I can see the full face of the coin, that is inside the esophagus. And if you will do opposite to it, it is for the lateral view. And they will confuse you in all these four X-rays. Done, guys? Now, next thing which you are going to study is what, guys? Next thing which you are going to study is your hiatus hernia. Anyone from the live who knows about hiatus hernia? Cardiac part of the stomach is going upward through the diaphragm opening. What is the name of the diaphragm opening, beta? It is your esophageal opening, beta. Okay. Now let's understand the concept. This is the normal structure. That's how my esophagus. So this is the second part of the esophagus. This is my third part of the esophagus. Then it is my stomach, right? And this is my duodenum. Okay. What I am trying to say, you guys, this kind of person who is going to have hiatus hernia, this kind of person can have chronic GERD. What is GERD? GERD is gastroesophageal reflux disease, or this person can have chronic hiccups, right? What will happen, this whenever this person will have the GERD thing and the hiccups thing, because of that, the pressure of the stomach, they are going to release their pressure on upward direction, right? It is going to release the pressure on upward direction, and because of that, what will happen, the opening, the esophageal opening, whenever they are pressuring on upper side, what will happen, this esophageal opening will get dilate. This esophageal opening will get dilate, and once it is getting dilate, what will happen, the last part of the esophagus, that is the third part of the esophagus, it will go upwards, as well as the fundus part of the esophagus will go, cardiac part or the fundus part of the esophagus will go also above your diaphragm. That is known as hiatus hernia. Let's see how it will go, guys. सब कुछ ही हटिया है तो. So now what is going to happen, the third part will come here, the cardiac part and the fundus part will come like this, and my stomach will start like this. It will become like this, right? This place here is known as what? This place here is known as your hiatus hernia. Done, guys? That is your hiatus hernia. Now, next thing which you are going to study is about what, guys? It is about achalasia cardia. Same, guys, the GERD will happen to this patient, and because of the GERD, now the stomach contents, they will go inside the esophagus. All of us know that stomach is having what, guys? Stomach is having acidic content, and stomach is having this protective layer for the acid, but esophagus is not having this protective layer. So whenever this acid content will go up to the esophagus, it will make my layers of the esophagus burn. It will try to damage the esophageal layers burn, right? Once it will try to damage it, the patient who is coming with the chronic GERD, what this patient is going to say, the patient is going to say, I am having burning sensation behind my chest, right? That is the clinical sign which you are going to see in a patient who is having acidity or GERD. You say gastroesophageal reflux disease. Because of that, what will happen, so on the lower side of esophagus we are having this esophageal sphincters. We call it the gate of esophagus as well as of stomach. So from esophagus the content is going to exit, and in stomach it is going to enter, right? What will happen, as well as, like if in GERD it will be opposite situation, right? So this lower esophageal sphincter, they will think I will get bigger so that the content inside my stomach cannot go up, right? So what I am going to have, I am going to have hypertrophy, bigger in the size of esophageal sphincter, lower esophageal sphincters hypertrophy. Let's write it down, guys. So in your achalasia cardia or esophageal achalasia, what you are going to see, you are going to see hypertrophy of lower esophageal sphincter. So your lower esophageal sphincter is going to get hypertrophied. Lower esophageal sphincter will get hypertrophied. Once it will get hypertrophy, now try to understand, guys, this person, if this person is eating food, will this food go down? Of course it will go down, but the patient will feel some kind of problem because it is bigger now, right? So the patient is going to feel some kind of problem at the time of swallowing the food, right? So we call it what? We call it dysphagia. This person is going to have one clinical feature, and this clinical feature is known as dysphagia. If you want to know more about dysphagia, you can see my another video which is clinical GIT part 2. right? I will ask everything about dysphagia. It is very important for your exams. In short, I will tell you here, dysphagia is what, guys? Dysphagia is your problem in swallowing. Problem in swallowing is known as dysphagia. Now, the patient is presenting with this kind of complaint. What you are going to do with this patient, guys? You are going to check this patient, or you are going to diagnose, or you are going to confirm your diagnose with the thing, and that thing is known as what, guys? The thing is known as barium swallow. So you are going to do one thing, and that thing is known as barium swallow. What is barium swallow, guys? In barium swallow, you are going to make this patient drink some radioactive material which is made up of this barium, right? Which is made up of this barium, and you are going to make this patient sit in front of the CT machine. And when this patient will drink the barium in CT machine, you can see how this barium is traveling down into the esophagus. Once this barium will enter into the last part of esophagus, it will give me some this kind of image. In this image, what is important, guys? The ending of the esophagus, which is on the lower esophageal sphincter. In this ending, if you will see, we are having this appearance, and this appearance is known as what, guys? This appearance is known as bird beak appearance. चिड़िया की चोंच जैसी appearance, right? This kind of appearance we are going to see in the patient. As well as, if you will notice, the diameter of the esophagus is also bigger. So dilated esophagus plus bird beak appearance, both of them are going to help me to diagnose this patient in what? In eclasia cardia, right? Suppose now this patient is not having, sorry, the hospital where this patient went, the hospital is not having the barium inside their hospital, or they are not having CT scan machine. How they can diagnose this thing? The second thing from which this patient can diagnose your eclasia cardia, that is what, guys? Okay, I will write it here. That is your endoscopy. That is endoscopy. What you are going to do? You are going to put the what you are going to do, guys? You are going to put the camera inside the oral cavity, and then this camera will travel to the esophagus, and it will see all the linings of the esophagus. And once it will reach to the last part of the esophagus, it will be inflamed, it will be bigger inside, right? It will get hypertrophied, so they will see very small opening from the esophagus which is entering inside the stomach. What we are going to do, we are going to take some cells from that last part of the esophagus as a biopsy, and we are going to send these cells to the pathological lab. Once the pathological lab will see these cells, they will say that hypertrophy of lower esophageal sphincter muscles is present, and this patient is having eclasia cardia. So these two things which are there, which you are going to do with uh, your eclasia cardia, right? Now, once you are 100% confirmed about this thing, then you have to do the treatment. What is the treatment you are looking for, guys? So the best treatment which you can do here is the surgery, and the name of that surgery is what, guys? Name of the surgery is Hellar's myotomy. What you are going to do in Hellar's myotomy, guys? In Hellar's myotomy, you are going to take this inflamed lower esophagus. So first of all, you are going to cut the abdominal cavity. You will enter inside the abdominal cavity. Once you are entering inside the abdominal cavity, you will find the place where you will have this hypertrophy of lower esophageal sphincter. Once you are there, what you are going to do, you are going to cut these muscles. This cutting the muscles which are present on the lower esophageal sphincter, this is known as myotomy. The first person who did this was Hellar uncle. That's why we call it Hellar's myotomy, right? So you are going to give these cuts to the muscle. Once you will give these cuts to the muscle, muscles will get elastic. So now the diameter of the esophagus will get bigger again whenever the food content is coming down inside the esophagus, right? But the basic problem here was what, guys? The basic problem here was the GERD. Because of the GERD, this get bigger now. So we have to treat the GERD. How we are going to treat the GERD in this kind of thing, guys? We are going to treat GERD with another operation which we are going to do with the Hellas myotomy, and that is known as fundoplication. What is fundoplication, guys? Try to understand. Suppose this image here is your 2D image. So you are going to take anterior part of the fundus as well as the posterior part of the fundus. Anterior part of the fundus will cover my esophagus anteriorly. Posterior part of the fundus is going to cover esophagus posteriorly, and we will bring this fundus part in front of the esophagus, and we are going to suture it. This kind of operation is known as fundoplication. Because of this operation, what will happen? The size of the stomach will get small. Once the size of the esophagus got small, what we are going to do, whenever this person is eating the food, now this person cannot eat the big meals or the large meals, so acid production will be very less. If acid production is less, it cannot create my gastroesophageal reflux disease, right? It cannot create the GERD thing. Important is what? Important is the surgery you are going to do in your ecclesia cardia. The name of the surgery is Hellar's myotomy with fundoplication. Okay, guys, so let's start our relations of the stomach, right? What are the relations which you should know of stomach? First of all, we are going to discuss few simple things. What are these? These are my greater curvature of the stomach and this is my lesser curvature of the stomach, right? The greater curvature and the lesser curvature. I am having these two curvatures. On this curvatures, what I am going to have? On this curvatures, I am going to have one fatty layer, right? On my greater curvature as well as on the lesser curvature. The fatty layer which is present on my greater curvature, it is greater omentum, and the one which is present on my lesser curvature, it is lesser omentum. लिखते भी जाते हैं साथ साथ में. So on lesser curvature I am having only one thing, and this thing is lesser omentum, and on greater curvature I am having another thing, that is greater omentum. What else I should know, guys? So I am having two important ligaments which are also present on this, guys. So from my greater curvature, one ligament is connecting with my diaphragm, right? Another name of diaphragm is known as phrenic muscles. That's why we call it what? That's why we call it gastrophrenic ligament. So in greater curvature, I am having one more thing, that is gastrophrenic ligament. And one more ligament which is present on this side from greater curvature towards the spleen. And this ligament is known as what, guys? This ligament is known as gastrosplenic ligament. The name of this ligament is what? The name of this ligament is gastrosplenic ligament. Let's write this also. So on greater curvature, I am having three things: greater omentum, gastrophrenic ligament, and splenic ligament. Done, guys. These are my relations of stomach on anterior side, or anterior as well as the lateral side. Before going towards the posterior side of relations, let's discuss the parts of the stomach. So all of us know that above part is fundus part, then we are having this body. If we will dissect this body layer by layer, what we are going to find? First of all, we are going to find the longitudinal muscles, then we are going to find the circular muscles, and then later we are going to find oblique muscles. So longitudinal muscles, circular muscles, and then oblique muscles. Done, guys. In the layer, the base, what you can say, inside the stomach, you are having this things, and you, what you are going to call these things, they are your gastric rugae. This gastric rugae is very very important for the stomach, guys, because they protect us from the acidic secretions of your stomach. Then we are having duodenal bulb, and then we will have duodenum. Done. Now, let's see the relations which are present on the posterior side of stomach. So, first of all, it will be what? It will be my diaphragm. All of us know that diaphragm is a dome-shaped structure. So, this dome-shaped structure is going to present behind the stomach also, right? Then all of us know second thing, that is the last opening of my diaphragm, that is aortic opening. From that aortic opening, I am going to have the celiac trunk, and from the celiac trunk, one artery is going posteriorly to the spleen. This artery is known as what, guys? This artery is known as splenic artery. Done. Now, which side is this, guys? This side is my left side, right? On the left side, just below the spleen, I am going to have one more organ, and this organ is what, guys? This organ is my kidney. So I am going to have my kidney behind the stomach. Superior part of left kidney. Superior part of left kidney is also present behind the stomach, as well as just above the kidney. I am going to have one gland. Name of this gland is what? Name of this gland is adrenal gland, suprarenal gland. Both of them are also present where? Behind the stomach. What else we are having, guys? So all of us know one more thing, that in my, this c-shaped organ is what, guys? This c-shaped organ is my duodenum, and in duodenum, in between the duodenum, I am going to have pancreatic head. So head of the pancreas is present in between the duodenum. Then the tail of the pancreas is present where, guys? Tail of the pancreas, sorry, the body of the pancreas is present behind the stomach, and the tail of the pancreas is trying to kiss the spleen. That's how it is going to be, right? Let's discuss the things which are here. So first of all, I am having my splenic artery. Then we are having superior part of the left kidney. Then we are having left suprarenal gland or left adrenal gland. And I am having the body of the pancreas also behind the stomach. As well as, if you know about transverse colon, so the part, not the whole transverse colon, but some part of the transverse colon will be present behind the stomach. We are going to call it what, guys? We are going to call it transverse mesocolon. We are going to call it what? We are going to call it transverse mesocolon. Let's write all the things which are present behind the stomach. So first of all, it is your diaphragm. Then second, you are having what? Second, you are having splenic artery. Third, you are having your superior part of left kidney. Then you are having left suprarenal gland, or you can say adrenal gland. Then you are having pancreas. To be specific, it is your body of the pancreas. And last thing which we have discussed is a part of the mesocolon, a part of your transverse colon, that is known as transverse mesocolon. So all these things are present where, guys? All these things are present behind the stomach. Done, guys? Now, next thing which we are going to discuss is what? Is the blood supply of the stomach. So all of us know on one side I am having greater curvature, on another side I am having lesser curvature of the stomach, right? On greater curvature and lesser curvature, we are having some blood supply. Okay, let's start from the fundus part. So here I am having small arteries, and the combination of this small arteries is known as what, guys? This is known as short gastric artery. Short gastric arteries. It is plural, guys. Okay, remember it. Then on the upper part of my greater curvature, I am having left gastro epiploic artery. On the lower part of greater curvature, I am having right gastroepiploic artery. Left gastroepiploic artery and right gastroepiploic artery. What about lesser curvature, guys? Again, on the upper side, I am having one artery, and this artery is known as left gastric artery. On the lower side of lesser curvature, I am having right gastric artery. So these five arteries are present where? On the stomach. Done, guys? I hope no problem until now. Everything is clear, guys. Can you reply me with the comments? Is everything going fine? All good? All well? Let's discuss the cells which are present in my GIT. Right? What are these cells, guys? I am having surface cells, chief cells, parietal cells, G cells, and enterochromaffin cells. All these cells are present in my GIT. Let's discuss all these cells one by one, guys. So we are going to start with the surface cells. What you should know about surface cells, guys? These surface cells are going to produce mucus, and this mucus is very rich in your bicarbonate, HCO3. It is what, guys? It is bicarbonate. And all of us know that this bicarbonate is very basic in nature. It is basic in nature, or you can say alkaline in nature. So what this thing will do? This thing will help me to neutralize acidity in GIT. So whatever the acid which is produced by this my stomach, this acid is going to get neutralized with the mucus which are produced by surface cell. Done, guys? Now second thing what I'm having chief cells. What about chief cells, guys? So these chief cells are going to secrete one enzyme, and the name of this enzyme is what, guys? It is pepsinogen. So these chief cells are going to secrete pepsinogen. What this pepsinogen will do? This pepsinogen will help me to digest proteins. Pepsinogen is going to help me to digest what, guys? Is going to help me to digest proteins. Done, guys. Now, the third cell which we are going to discuss, it is parietal cells. Parietal cells is very important cell, guys, because it is doing two very important function in our body. Out of them, the first function is what, guys? It is producing intrinsic factor. We call it IF. It is producing intrinsic factor, and this intrinsic factor is doing what, guys? This intrinsic factor is helping me to absorb my vitamin B12. Intrinsic factor is helping me to absorb vitamin B12. Where in vitamin B12, guys? It is your FMG exam question. It is going to absorb it in your terminal ileum. It is going to absorb in terminal ileum. What is the another thing this parietal cells gonna do? That is your producing gastric acid. It is going to produce gastric acid. What is the name of this acid? Hydrochloride acid. Hydrochloric acid. Then what about G cells? G cells are going to produce gastrin, and enterochromaffin cells are going to produce histamine. Gastrin and histamine. What you should know, guys, important is about gastrin and histamine. So my gastrin as well as my histamine, what they are going to do, they are going to promote, they both are going to do what, guys? They both are going to do promote your parietal cells to produce more hydrochloric acid. They are going to promote my parietal cells to increase the acid, right? Now, what is the potent inhibitor of gastric acid secretion? The potent inhibitor of your gastric acid secretion, it is what, guys? It is your prostaglandins. It is what, guys? It is prostaglandins. guys एक मिनट देना यार important call आ रहा है. Now, all these things are going to absorb where in the intestine is also your FMG exam question. Now we are going to study about all these things. So vitamin B12 and folate, they are going to absorb where, guys? They are going to absorb either in duodenum as well as they are going to absorb in your jejunum. Carbohydrates, fats, protein, mineral, vitamin, folic acids. What about all these things, guys? They are going to absorb in jejunum. Last thing is about bile salts and vitamin B12. It is already asked. The answer is what, guys? The answer is terminal ileum. Answer is terminal ileum. Now the parts of the stomach. What are the parts of the stomach which you should know? The stomach from the esophagus, it is going to convert into the cardiac part, then fundus, then body, then I am having pyloric antrum, pyloric canal, the pylorus part, and then duodenum. What we are going to study now, that is your pyloric stenosis. What is pyloric stenosis, guys? So in pyloric stenosis, you are going to have, or it is hypertrophy of pylorus part. It is hypertrophy of pylorus part of your stomach. Done, guys. Where you are going to see it, guys? Most common, you are going to see it in pediatric age group. And in pediatric age group, where you are going to see it in 4 to 8 weeks of babies. So in these small babies, what will happen? Mother will come to your pediatric emergency and she will ask that whenever I breastfeed my baby, after 15 to 30 minutes, my baby started vomiting. Right? So these are going to present with guys, what guys? So the patient is going to present with vomiting, and this vomiting is projectile as well as non-bilious vomiting. Projectile non-bilious vomit. Right? What is projectile non-bilious vomit, guys? Try to understand this thing. If a person is doing vomiting, right? If this person is doing vomiting on his friend's foot, this vomit is going away from the person. That is projectile vomiting. If this person is going to vomit on his own food, that is your non-projectile vomiting. What else, guys? If this person, when this person is vomiting, in this vomiting, if you can see the green color, this green color represent the bile juice. Green color represent bile juice. So if vomiting is of green color, it is bilious vomiting. If there is no green color in the vomiting, you will say it is non-bilious vomiting. Done, guys. So this patient is going to have projectile non-bilious vomit, as well as when you will do the blood test of this patient will have potassium as well as chlorine deficiency in the blood, hypokalemia and hypochlorinemia. Okay. Then when you will try to palpate this patient, when you will try to palpate from your hand, you are going to find one very important thing. That is what, guys? That is olive like mass. Olive like mass at the time of palpation. For confirmation, what you will do, for confirmation, you can do either the CT scan or your X-ray. In CT scan or in X-ray, what you are going to find? You are going to find this kind of appearance, and this kind of appearance is known as what, guys? This kind of appearance is known as single bubble sign. Single bubble sign. Single bubble sign is seen in where? Single bubble sign is seen in pyloric stenosis. Once you will confirm the diagnosis, guys, next thing what you are going to do is to treat this patient. For treating this patient, you are having two options. First of them is surgery. So for treating this option, for treating this pyloric stenosis, you are going to do the surgery, and the name of this surgery is pyloromyotomy. Same thing what we have done in the lower esophageal sphincter. There we have done a large myotomy. Here we are going to cut the pylorus muscles of the stomach. That's why we call it pyloromyotomy. After this surgery, we are going to tell the patient, bring your baby in every 1 month. If there is no problem, well and good. If there are some kind of problem, then we have to do one major surgery, and gastrectomy, guys. Gastrectomy is cutting the part of the stomach, throwing it outside from the body, and then connecting the ending of your stomach with the side of your duodenum. So what we are going to do, we are going to do gastrectomy. With that, you are going to join the ending of the stomach with the side of the duodenum. This joining is known as what, guys? This joining is known as anastomosis. Guys, anastomosis is of three types. You can do end to end anastomosis, in that you are taking the end part of both organs. Another one is end to side anastomosis, in that you are taking one organ's ending and another organ's side part, and then you can do side to side anastomosis, in that you are taking side part of both organs, right? Here we are going to do end to side anastomosis. Can you see here? Ending of the stomach and the side part of the duodenum. End to side anastomosis. Done, guys. Now we are going to have diaphragm. Everything is clear? Diaphragm. Diaphragm के बारे में क्या पता होना चाहिए, guys? Diaphragm is your dome shaped structure. And this structure is present where, guys? This structure is present in your inferior to pleural cavity. What you should know about this structure, it is made up of muscles as well as tendons. That's why we call it musculo tendinous structure. And this structure is supplied by a nerve. The name of that nerve is phrenic nerve. And we all know what is the root value of phrenic nerve, guys. What will be the root value of phrenic nerve? Anyone? It will be C3, C4 and C5. Done. Now this one, so the diaphragm we are making, it is like an umbrella shaped structure or the dome shaped structure, in that this one here is what, guys? It is your anterior surface. Then this one here, it is lateral arcuate ligament. This one here is your medial arcuate ligament. Then we are having right crus and left crus. And right in between your right crus and left crus, you are having this thing, and this thing is known as what, guys? This thing is known as middle arcuate ligament. Middle arcuate ligament. Ending of right crus and left crus is important, guys. So the ending of my right crus is coming out from L2, sorry, L3, and left crus is coming out from L2. So these are the positions of the endings of my right as well as the left crus. In diaphragm, we are going to have two things. Out of them, the first thing is the major openings, and the second thing which we are going to discuss is what, guys? It is your minor openings. Major openings can be remembered as Virat obeys Anushka. So the major openings can be remembered as Virat obeys Anushka. Virat is for what, guys? Virat is for Vena Keval opening. Obeys is for your esophageal opening. And Anushka is for what? Anushka is for aortic opening. From all these openings, something is coming out. What are these things, guys? The first thing or the second, so from vena cava opening, I am going to have two things. What are these two things, guys? I am having inferior vena cava as well as I am having right phrenic nerve. From esophagus, I am going to have three things. First of all, it is esophageal itself. Second is esophageal artery. And the third one is your vagus nerve. This esophageal artery, guys, we have already discussed. This esophageal artery is the branch of what, guys? It is the branch of left gastric artery. Then we are having aortic opening, and in aortic opening, again, three things are coming out. As per the name say, it is aorta. Then we are having thoracic duct, and then we are having azygous vein. Aorta, thoracic duct, and azygous vein. All these three things are coming out from where? All these three things are coming out from my aortic opening. Where is my vena cava opening? Here. This is my vena cava opening. This is my aortic esophageal opening, and here I am having aortic opening. Vena cava, esophageal, and aortic opening. That is all about your major openings. Now let's discuss the minor openings. For that, this V-shaped organ here, structure here, this V-shaped structure is what, guys? It is your xiphoid process. This xiphoid process is present at the level of P9. This xiphoid process is present where, guys? It is present at the level of your thoracic vertebra number 9. Okay. On the both side of the xiphoid process, we are having this minor opening, and the name of this minor opening is what, guys? The name of this minor opening is your opening of Morgagni and space of Lare. So it is having two names. The names are opening of Morgagni and space of Lare. What is coming out from here? The thing which is coming out from here, it is your superior epigastric artery. And this superior epigastric artery is the branch of what, guys? It is the branch of interthoracic internal thoracic artery. Done, guys. Any problem until now? I hope everything is coming out clear. Now, the second opening, before that, try to understand just side, just lateral to my lateral arcuate ligament. I am going to have one thing, and this thing is what, guys? This thing is my ribs number 12th. So it is my 12th rib, and the area which is present below the 12th rib is known as what, guys? The area present below the 12th rib is known as my subcostal area. And in this subcostal area, from lateral arcuate ligament, I will have opening for the artery, one opening for the vein, and one opening for the nerve. What are all these three things, guys? The name of these three things are subcostal artery, subcostal vein, and subcostal nerve. Done, guys? Then let's come to the right crus. On right crus, I'm having only one opening, and this opening is for one nerve. And the name of this nerve is what, guys? The name of this nerve is right phalangic nerve. What about the left? From left, again the name will be same, but side will get changed, right? So it is what, guys? It is my left phalangic nerve. As well as one vein is also going to come from here, guys. The name of this vein, already we have discussed this vein, guys. That is your hemiazygous vein. Then, guys, all these are my minor openings. Now, next topic which we are going to study is abdominal aorta, as well as the celiac trunk, Bahubali and Devsena. Then I am having superior mesenteric artery, Sama. Then at the navel I am having inferior mesenteric artery, and here it is common iliac artery. Done. Now, the location of this all arteries is very important. What about celiac trunk? Celiac trunk is located at the level of my lower border of T12, right? Superior mesenteric artery is also present at the lower border of L1. Inferior mesenteric artery is not present on the lower border, guys. It is present on the body of L3. What about common iliac artery? Common iliac artery is present again on the lower border of L4. Done, guys. Celiac trunk is going to do what, guys? Celiac trunk is going to supply my foregut. Celiac trunk is going to supply where? It is going to supply my foregut. Superior mesenteric artery, it is going to supply midgut. Inferior mesenteric artery, it is going to supply where, guys? It is going to supply my hindgut. Foregut, midgut, and hindgut. What about common iliac artery? Common iliac artery is going to supply my lower limbs. So this common iliac artery will have again two arteries, external iliac and internal iliac artery. One thing which you should know about internal iliac artery is what? This internal iliac artery is connected in your intrauterine life with your umbilical arteries. What you should know, umbilical arteries and umbilical vein, they both are same as pulmonary arteries and pulmonary vein. In pulmonary arteries, we are having deoxygenated blood as well as in your umbilical arteries. In pulmonary veins, we are having oxygenated blood as well as in your umbilical veins. Done, guys? Now, foregut is what, guys? So your foregut is starting from your esophagus. No, not esophagus. Foregut is starting from where, guys? It is starting from third part of your esophagus till ampulla of Vater. We have already discussed what is ampulla of Vater, right? What about midgut, guys? Midgut is starting from ampulla of Vater till junction between. It is the junction between your proximal 2/3 and distal 1/3 part of your transverse colon. What about the hindgut? Hindgut is again starting from your junction between proximal 2/3 and distal 1/3 of transverse colon, and it is ending where? It is ending till upper half of your rectum. Done, guys? Now let's see the posterior as well as the lateral branches. So in lateral branches, first of all, we have studied that one artery is going to supply to the diaphragm, and this diaphragm artery is known as what, guys? This is known as inferior phrenic artery. Then one artery is going to supply to adrenal gland. This is known as middle suprarenal artery. One artery will directly supply to the kidney, that is your renal artery. And one artery which is supplying to your gonads, that is your reproductive organ, that is known as what, guys? Gonadal artery. Done. These are my lateral branches. What about the posterior branch, guys? So on posterior side, I am having four pairs of lumbar arteries, and one is your what? One is your median sacral artery. So I am having four pairs of lumbar arteries as well as one pair of median sacral artery. We already know that the upper gut is supplied by what? The upper gut is supplied by your celiac trunk, and celiac trunk is very important because it is having so many branches. Let's make the flow chart of celiac trunk. What you should know here, this celiac trunk is going to have how many branches, guys? This celiac trunk is going to have my three branches. Out of them, the first branch is left gastric artery. What is the first branch, guys? The first branch is left gastric artery. And this left gastric artery we have already discussed. This left gastric artery is going to give me one supply, and that is what, guys? That is my esophageal artery. Left gastric artery is going to give me esophageal artery, and this esophageal artery is going to supply where, guys? This esophageal artery is going to supply to the third part of the esophagus, also known as abdominal esophagus, right? What about the second branch? The second branch which is coming out from your celiac trunk, it is my SMA. Oh, sorry. It is my splenic artery. This splenic artery is going to give six branches. One, two, three, four, five, six. Out of them, first three branches are for pancreas. Next two branches are for stomach. And the last branch is for spleen itself. Right? What are these first three branches of pancreas, guys? These are my dorsal pancreatic artery, Then I am having atria pancreatica magna. Magna in Latin, in English, you are going to call it the artery which is supplying to the body of pancreas, right? And the third one is atria pancreatica cauda. Cauda means what, guys? The artery which is going to supply to the tail of pancreas. What about next two arteries which are going to supply in my stomach? The first artery which is going to supply in my stomach, it is my, anyone? It is my short gastric artery, right? What about the second artery, guys? The second artery which is going to supply, it is my left gastro epiploic artery. I have already discussed in earlier when we were discussing about our stomach blood supply. We have discussed short gastric artery is going to supply to the fundus, left gastroepiploic artery is going to supply the upper part of greater curvature, right? And then from spleen, I am going to have only one branch, and this branch is known as hilar branches. Now, the last one is what, guys? The last artery which is going to supply me, that is my proper hepatic artery. This common hepatic artery is going to give me two branches. First one is proper hepatic artery, and another one is gastroduodenal artery. This gastroduodenal artery is going to supply where, guys? This gastroduodenal artery is going to supply to the pylorus part of my stomach. It is going to supply where? It is going to supply to the pylorus part of stomach. Now, proper hepatic artery is also having two branches, and three branches, and gastroduodenal artery is going to have two branches, right? What are the branches which are supplied by proper hepatic artery? Proper hepatic artery is giving me three branches. Out of them, the first branch is my right gastric artery. Then I am having left hepatic artery. Then I am having right hepatic artery. This right hepatic artery, guys, this right hepatic artery is going to give me one more branch which is going to supply where? Which is going to supply to my gallbladder. And then the name of this artery is cystic artery. The name of the artery is what, guys? It is cystic artery. What about gastroduodenal artery? Gastroduodenal artery is going to give me two branches. What are the names of these two branches, guys? First of all, it is my right gastroepiploic artery, and I am having superior pen, इसको पूरा लिखना पड़ेगा. It is my superior pancreatico duodenal artery. Superior pancreatico-duodenal artery. This superior pancreatico-duodenal artery is going to supply where? The superior pancreatico-duodenal artery is going to supply to D1. It is going to supply to D2, as well as it is going to supply my upper part of head of pancreas. Done, guys? Now let's draw all these arteries, guys. So if you will draw it, it will be easy for you to remember, right? What we have discussed that abdominal aorta is going to give one branch, and this branch is known as what, guys? This branch is known as celiac trunk. Then we have discussed the first branch of the celiac trunk, that is your gastric artery. Which gastric artery? It is supplying to my upper part of lesser curvature. We call it left gastric artery. This left gastric artery is giving one branch. The name of this branch is what, guys? The name of this branch is अटक ही गया क्या? Is your esophageal artery. And this esophageal artery is supplying to the lower part of your esophagus. And the second artery which we have discussed already, the name of that artery is what? The name of that artery is your splenic artery. So your artery which is going to go posterior to stomach, that is what, guys? That is splenic artery. This splenic artery is very important. It is giving 6 different branches. Out of them, first 3 branches are for pancreas, dorsal pancreatic artery, atria pancreatica magna, and atria pancreatica cauda. All these 3 are what, guys? All these 3 are the branches of splenic artery which is supplying to my pancreas, right? Then we are having small arteries on the fundus of the stomach. We call it short gastric arteries. Short gastric arteries. Then we are having one more artery from the stomach that is supplying to the upper curvature, upper part of my greater curvature. And this upper part of the greater curvature artery name is what, guys? It is your left gastroepiploic artery. It is your left gastroepiploic artery. This is my dorsal pancreatic artery. This is my atria pancreatica magna. Here is my atria pancreatica cauda. Then we are having short gastric arteries and left gastroepiploic artery. That's all about your splenic artery. Last branch here. This is what, guys? Last branch is hilar branches. Now, the third artery which we are going to discuss here is what, guys? The third artery which we are going to discuss is your common hepatic artery. Here is my common hepatic artery, guys. So this is my common hepatic artery. This common hepatic artery is giving me 2 branches. One is proper hepatic artery and another one is gastroduodenal artery. This is my proper hepatic artery, and here I am having gastroduodenal artery. What about proper hepatic artery, guys? Proper hepatic artery is giving me how many branches? 2 branches. Out of them, the first one, 3 branches. Out of them, the first branch is right gastric artery. Then I am having left hepatic artery. Then I am having right hepatic artery. And this right hepatic artery is giving one branch. This branch is what, guys? This branch is my cystic artery. What about gastroduodenal artery? This gastroduodenal artery is giving one artery. This is known as superior pancreatico-duodenal artery. And another branch is on the lower curvature. And it is what, guys? It is your, sorry, not on lower curvature, lower part of greater curvature. And this artery is what, guys? This artery is your right gastroduodenal epiploic artery. This one is your right gastroepiploic artery. Done, guys. Now let's see some clinical things, guys. Out of them, the first thing which you are going to see, it is what, guys? It is your peptic ulcers. What are peptic ulcers, guys? Peptic ulcers are characterized by discontinuation, where, guys, they are the discontinuation in the inner lining of GI tract, in the inner lining of my GI tract. Okay, guys. Why these ulcers are happening? They are happening due to increase in the secretion of, cause is what, guys? The cause is increase in secretion of hydrochloric acid, that is my gastric acid, as well as pepsin. So pepsin and hydrochloric acids are getting increased in my stomach. Because of that, they are destroying the inner lining of my GI tract, and because of that, now the person is having peptic ulcers, right? What is the site, guys, where they are present? The site is stomach, or it can happen to the proximal part of duodenum, that is D1. So if it is happening inside duodenum, we will call them duodenal ulcers, and if it is happening in the stomach, we are going to call them peptic ulcers. Done, guys. One thing which you should remember here, it is what, guys, that this kind of ulcers, they are going to extend. They are going to extend where, guys? They are going to extend to the muscularis propria layer. FMG एग्जाम क्वेश्चन, गाइस. मस्क्यूलरिस प्रोप्रिया, उनको ये नाम पसंद है बहुत. मस्क्यूलरिस प्रोप्रिया ऑफ योर गैस्ट्रिक एपिथेलियम. नाम याद रखना, गाइस. These are going to extend where? To the muscularis propria layer of my gastric epithelium. What are the symptoms this person going to have? This person is going to have, first of all, epigastric pain. And when this person will have this pain, this person is going to have this pain after meal, within 15 to 30 minutes. So within 15 to 30 minutes after having food, this person will have epigastric pain. This kind of ulcers are having potential to cause bleeding. How they will cause bleeding, guys? So this kind of ulcers are going to erode my gastroduodenal artery. So the bleeding is going to happen from which artery, guys? Bleeding is going to happen from gastroduodenal artery. Gastroduodenal artery is the branch of which artery, guys? Anyone can tell me if anyone is present here? Gastroduodenal artery is the branch of common hepatic artery. Great. Now, let's talk about causes. What are the causes this person is going to have? So we are going to have two important cause, guys. Out of them, the first, which is the most common cause for this kind of thing, that is what, guys, the most common cause is the name of bacteria, and the name of the bacteria is H pylori. We call it Helicobacter pylori. What we are going to call it, guys, we are going to call it Helicobacter pylori. This kind of bacteria is going to do 88% peptic ulcers. What about rest 22%, guys? This rest 22% is done by NSAIDs. How these NSAIDs are going to do, guys? So these NSAIDs are going to block one enzyme. The name of the enzyme is COX-1 enzyme, and this is the same enzyme which is helping me to produce prostaglandins. So if there is no COX enzyme, there will be no prostaglandins. What we have studied about prostaglandins, guys, prostaglandins are the potent inhibitor of your gastric acid secretion. If there is no prostaglandin, gastric acid will forget to stop. Once it will forget to stop, what will happen? More acid inside the stomach, which will destroy the inner linings of the stomach, which will lead to my peptic ulcers. Done, guys. Now, what about the treatment, guys? So for treatment, we are having two, three options. First of all, we are going to do triple therapy. What happens in triple therapy? In triple therapy, we are going to give combination of proton pump inhibitors, as well as we are going to give them antibiotics. So first of all, any prazoles like omeprazole, pantoprazole, all these are your PPIs. What about antibiotics? Either you can give clarithromycin, as well as you can give metronidazole. With clarithromycin, you have one option, that is what, guys? That is amoxicillin. So one of these guys, either the clarithromycin or amoxicillin plus metronidazole, you are going to give, and you are going to give it around 7 to 14 days. After that, you will check the patient. If patient is getting cured, well and good. If not getting cured, you are going to start quadruple therapy. In quadruple therapy, you are having this triple therapy, plus you are going to give one more drug, and this drug name is what, guys? This drug is bismuth. And this bismuth is doing what? It is giving me extra protective layers just in my inner lining of stomach, right? Even after quadruple therapy, if patient is not getting cured, then we will go for the surgical options. And the surgical options are what, guys? The surgical options which you should know here, out of them, the first one is your vagotomy, and the second one is your partial gastrectomy. Vagotomy and partial gastrectomy. Now, we are having blood supply of midgut. What we have studied about midgut? We have studied that from ampulla of Vater till proximal two-third and distal one-third of my transverse colon, I am having midgut, right? Midgut is supplied by which artery, guys? Midgut is supplied by SAMA, superior mesenteric artery. Okay, so superior mesenteric artery is going to have so many branches. Let's discuss them one by one. The first branch is what, guys? The first branch is inferior pancreatico duodenal artery. This inferior pancreatico duodenal artery is going to have supply to what, guys? It is going to have supply to D2, D3, D4, as well as the lower part of head of pancreas. That is my first artery. What is my second artery, guys? Second artery which is going to supply will be my jejunal artery. Arteries, guys, it is plural. The third one is ileal arteries. The fourth one will be my very important artery, and this is known as ileocolic arteries. Why it is important, guys? Ileocolic artery is important because it is going to give me two branches. What are these two branches, guys? 4A and 4B. One is your anterior cecal arteries, another one is your posterior cecal artery. This 4B is going to give again one branch, and the name of that branch is 4B1. That is supplying to appendix. We call it appendicular artery. What about fifth and sixth one, guys? The fifth one is your right colic artery, and sixth one is your middle colic artery. Right colic artery and middle colic artery. So all these things you should know. How to draw this diagram, guys? So we have already prepared few intestines and all these things. Now remember, guys, the first artery which is supplying where, it is supplying to my lower part of head of pancreas as well as the duodenum, second, third and fourth part. This is my first artery, that is inferior pancreatico-duodenal artery. Then I am having jejunal and ileal artery. Both of them are going to supply by one branch only, but when it is supplying to duodenum, when it is supplying to jejunum, we are going to call it jejunal artery. When it is supplying to ileum, we are going to call it ileal arteries. So this is what, guys, this is my second and the third branch. Fourth branch is what, guys? Fourth branch is ileocolic artery. It is going to supply the last part of the ileum, that is terminal ileum, as well as to the colon. Now this ileocolic artery is going to supply anteriorly and posteriorly, right? We call it 4A and 4B. Anterior cecal artery and posterior cecal artery. Then this posterior cecal artery is going to supply where? It is going to supply to appendix 4B1, appendicular artery. What about fifth and sixth artery, guys? Fifth artery is my right colic artery, and sixth artery is my middle colic artery. All these are the blood supply of midgut. What about hindgut, guys? So the hindgut is supplied by your inferior colic arteries, inferior mesenteric artery. Inferior mesenteric artery is going to have only three branches. Out of them, first one is your left colic artery, second one is your sigmoidal artery, and the third one is your superior rectal artery. What you should know here, you should know that my inferior mesenteric artery itself descend down to convert into third branch, that is my superior rectal artery. So suppose guys, somewhere here I am going to have my inferior mesenteric artery. The first branch is what guys? First branch is my left colic artery. Second branch is my sigmoidal artery. And in third branch, this is itself going to descend down and going to supply where? It is going to supply to upper part of the rectum, and we call it superior rectal artery. Done? Now, what is horseshoe kidney, guys? So, horseshoe kidney is your congenital abnormality. It is the congenital developmental disorder. It is the congenital developmental disorder where what will happen? The both kidneys, your both kidneys are going to fuse with each other. We call it horseshoe kidney, right? Can you appreciate this CT scan, guys? Can you see this thing here? This is your horseshoe kidney. Here also. Why it is important? Because if a person is having horseshoe kidney, the person can suffer from hydronephrosis. The person can have more kidney stones, more kidney infection, as well as the kidney cancer. Especially it is Wilms tumor or the carcinoid tumor. Done. Now let's start the portal vein, guys. Portal vein is again very important. Combination of, it forms the combination of splenic and your superior mesenteric vein. It is forming the combination of splenic as well as superior mesenteric vein. Can you see here, guys, in this diagram? Splenic vein is coming here, and your superior mesenteric vein. They both will come and to the level of L2, and they will give one this small vein. This is known as portal vein. So first of all, the location is behind the pancreas. So if it is behind the pancreas, what is going to happen? Behind the neck of the pancreas, I am having superior mesenteric vein. Then at the level of L2, what will happen? At the level of L2, this superior mesenteric vein and splenic vein, they both will come and join, and it will give rise to my portal vein. What is the length of portal vein, guys? The length of portal vein is approximately 8 centimeters. Then this portal vein will give right and left branches. From liver. So the right and left branches from the liver is going to drain where? It is going to drain in your portal vein. Important is the pressure of this vein, guys. What is the pressure of this vein? The pressure of this vein is around 5 to 10 millimeters of mmHg mercuries. Then guys, what will be the function of portal vein? The function of the portal vein is so the blood from GIT after absorption, it is going to enter into your liver. Okay, it is going to enter where, guys? It is going to enter into your liver. Once it will get enter into the liver, the place from where it is going to enter, it is portal vein. And why it is going to enter into the liver? It is going to enter into the liver just because we want to detoxify it. What is the function? The function is detoxification. Blood will get detoxify into the liver. How? Portal vein will supply to the liver. This portal vein will enter into a ligament, and the name of this enter from a ligament. That hole is known as porta hepatis, and the ligament is known as what, guys? This hole is present in the hepatoduodenal ligament. Where this hole is present, guys? This hole is present in hepatoduodenal ligament. So what all things are going to come out from porta hepatis? Total we are having three things which are going to come out from porta hepatis. That is your proper hepatic artery, then you are having common bile duct, and then you are having portal vein. So common hepatic artery, common bile duct, and portal vein, all these things are going to come out from a hole which is present in your duodenal ligament, and the name of that hole is what? The name of that hole is porta hepatis. Done, guys? Now let's make this diagram, guys. So we are going to understand what actually happens here. Try to understand this level here is my L2 level. Okay. In this level, what is going to happen? In this level, splenic vein will going to come. Okay. And superior mesenteric vein is also going to come, and they both will attach with each other. So what all things are coming? I am having splenic vein, and I am having superior mesenteric vein. They both will attach and give one vein, and this vein will go towards the liver. And this is your what? This is your portal vein. This portal vein is going where? This portal vein is going to the liver for the detoxification of your blood. This is known as left hepatic vein and right hepatic vein. This right hepatic vein will have cystic vein also. Same like your arteries, right? Now, portal vein is also connected with your upper part of lesser curvature. This is known as left gastric vein, and it will give one more vein which is from the lower part, that is right gastric vein. Okay, one more vein which will come out from which will bring here, it is what guys, it is your para umbilical vein. And then here we have studied already one artery, superior pancreaticoduodenal artery. Now we are having superior pancreaticoduodenal vein. Superior pancreaticoduodenal vein. This superior mesenteric vein is going to give one branch, and this branch is known as what guys? This branch is known as gastroomental vein. Gastroomental vein. What about my splenic vein? The splenic vein is going to attach with my inferior mesenteric vein. What all veins are going to attach with my superior mesenteric vein? They are total 5 in numbers. First of all, it is gastroomental vein. Then I am having jejunal vein. Then I am having right colic vein. Then I am having ileocolic vein and middle colic vein. All these veins are going to supply to the portal vein, and then portal vein will detoxify it, and then it will again enter into your inferior vena cava into the circulation, right? To make this diagram simple, we can do it like here. Let's make it very fast guys. So left and right hepatic vein, right? They are giving me portal vein, right? This portal vein is at the level of L2. Here I am having what? Here I am having splenic vein and superior mesenteric vein. Portal vein is giving again some branches. What are these branches? So I am having left gastric vein, right gastric vein, and I am having umbilical vein and superior pancreaticoduodenal vein, right? And from this I am having inferior mesenteric vein. Let's label it guys. So this is what is the main vein. It is my portal vein. They are going to supply to the stomach. In stomach I am having left gastric vein and right gastric vein. Then from down it is my superior pancreaticoduodenal vein. This is my umbilical vein. Now here I am having left hepatic vein. Here I am having right hepatic vein. This right hepatic vein is also having cystic vein. This here on the posterior side of the pancreas I am having splenic vein. Splenic vein is attaching with my inferior mesenteric vein, and they both are attaching at the level of L2, which both guys superior mesenteric vein as well as the splenic vein, they both will attach to the L2. Then from L2 they will give rise to my portal vein. Done guys. Now inferior vena cava. Inferior vena cava is what guys? All of us know what is this. Important points inside inferior vena cava is the left suprarenal gland, the left suprarenal vein, and left gonadal vein. They both are going to drain where? They both are going to drain into your left renal vein. And the location of inferior vena cava is what guys? It is posterior to liver. It is posterior to liver. Now let's see the veins which are attached with inferior vena cava. First of all, we are having inferior phrenic vein. It will be on the both side, right? Inferior phrenic vein. Then this is my left side, this is right side. With liver, I am going to have my hepatic vein. This is my right suprarenal vein. This is my right renal vein. And from my gonads, I will have gonadal vein, right? Also, right gonadal vein. And then I am having small branches. These are known as what guys? These are known as my lumbar veins. What on the left side you have to remember? So on left side I am having left renal vein, and this left renal vein is having some branches. One is left suprarenal vein and left gonadal vein. Left suprarenal vein and left gonadal vein. They both are attached to what? They both are attached to left renal vein. These are the lumbar veins. Now, portocaval anastomosis. What is portocaval anastomosis, guys? The site of portocaval anastomosis is your rectum, then esophagus, then umbilicus. Okay. So what will happen? From portal system, your superior rectal vein will come, and from your caval system, your middle inferior rectal vein. And they both are going to attach with each other, right? What about esophagus, guys? So from esophagus, we are going to have esophageal branch of left gastric vein, and from caval system, we are going to have esophageal branch of accessory hemiazygous vein. They both are going to come and they both are going to attach with each other. What about umbilicals, guys? So from here, I am having para-umbilical vein from my portal system and para-umbilical vein from my portal system, and From caval system, I am going to have superficial vein of anterior abdominal wall. It is my superficial vein of anterior abdominal wall. So on three sides, I'm going to have the combination of portal vein as well as my inferior vena cava. What are all these three things, guys? These are my superior rectal vein from portal system, which is coming to attach with my middle inferior rectal vein from caval system. Then esophageal branch of left gastric vein and esophageal branch of accessory hemiazygous vein. They both are going to combine with each other, and then para-umbilical vein and superior vein of anterior abdominal wall, they both are going to come and attach with each other. Okay, guys. Next thing which you are going to study is your liver cirrhosis. So, guys, in liver cirrhosis, what you are going to find? So, in easy words, what is liver cirrhosis, guys? In your liver, you are going to have nodules as well as you are going to have fibrosis. That is known as your liver cirrhosis. What are the causes, guys? Causes are, most common cause is your alcohol. जो बच्चे दारू पीते हैं उनको नहीं पीनी चाहिए क्योंकि लीवर सिरोसिस हो जाता है. ठीक है. Then we are having hepatitis. Hepatitis B or hepatitis C. If the patient is non-alcoholic, then it can happen from fast food also. Junk food. Maggie is a junk. Okay? Other than that, it can happen from some metabolic disorders also. कौन कौन से मेटाबॉलिक डिसऑर्डर होते हैं वी विल स्टडी व्हेन वी विल स्टडी अबाउट लिवर सिरोसिस फुल टॉपिक लिवर सिरोसिस इटसेल्फ इज 1 hour टॉपिक ओके वी विल डू इट समडे लेटर अभी इतना सा जान लो बस व्हाट एक्चुअली हैपेंस इस कंडीशन में द लीवर विल गेट श्रिंक एंड द पोर्टल वेन विल गेट ब्लॉक once the liver gets shrink and portal vein got blocked because of that now the blood flow will get changed. This 5 types of blood flows is very important, guys. I am definitely going to ask in your final exams what are 5 different types of blood flow that will happen after liver cirrhosis. So out of them the first one is what, guys? So the first one is from my portal vein. This vein is going into the left gastric vein, then to the esophageal vein, then to azygous vein, and then to superior vena cava. Let's write it down, guys. Maybe 10-15 minutes more, and then we will finish our topics, I guess. Right? Abnormalities, duodenum, and congenital abnormality, that is Meckel's diverticulum. Max to max, it will take half an hour, guys. So, from portal vein, what is going to happen? From portal vein, the blood will go to my left gastric vein. From left gastric vein, it will go to esophageal vein. And from esophageal vein, it is going where? It is going to azygous vein. And from azygous vein, it is going to superior vena cava and then to right atrium. Done. Important here is your esophageal vein. Esophageal vein is very important because now blood flow is changed. What will happen? This esophageal vein will get dilate. Esophageal vein will get dilate. Once my esophageal vein got dilate, patient can suffer from esophageal varices. Corkscrew appearance will be seen in angiography or venography, right? Then what is my second one, guys? In second one, portal vein is giving supply to inferior mesenteric vein. Then from inferior mesenteric vein the blood is going into superior rectal vein. From superior rectal vein it will go to middle rectal vein. From middle rectal vein it will go to inferior rectal vein. From inferior rectal vein now the blood is going into internal iliac vein. From internal iliac vein now blood is going into common iliac vein. Then it is going into inferior vena cava. And from inferior vena cava the blood is going to go in right atrium. Done. The third one is what, guys? The third one is from portal vein the blood is going into para umbilical vein. From para umbilical vein it is going into superficial epigastric vein. Then from superficial epigastric vein it is going into great saphenous vein. From great saphenous vein it is going into femoral vein. From femoral vein it is entering inside external iliac vein. From external iliac vein it is coming into common iliac vein, then to inferior vena cava. And from inferior vena cava it is going where? From inferior vena cava it is going to my right atrium. Now what are the fourth and fifth one, guys? Fifth one is easy, fourth one is also not very big, guys, so no need to get afraid. Only second and third one is big, so try to learn it, guys. You can do it, I know. The fourth one is the portal vein is supplying to the veins of ascending and descending colon. Okay. From there it will go to inferior vena cava, and from inferior vena cava it will go to right atrium. What about the last one, guys? In last one my portal vein is going to go into the lumbar veins. From lumbar veins it is going to go into the inferior vena cava, and from inferior vena cava it will go into the right atrium. Done. Now the abnormalities of esophagus. In abnormalities of esophagus you should know these four important things, guys. Out of them the first one is what, guys? The first one is your normal relation of your trachea and esophagus. So that's how they normally presents. It is your normal presentation, guys. It is your normal presentation. Second one here is what, guys? It is your esophageal stenosis. Can you see this part here, guys? So my esophagus got constricted, and it is pathological constriction. It is not normal constriction, guys. Okay. So here what you are going to remember, here you are going to remember that in such cases, the newborn babies, they will face a disorder, and this disorder is known as dysphagia. We have already discussed what is dysphagia, right? Now, the third one is what, guys? The third one is your pure tracheoesophageal fistula. It is pure tracheoesophageal fistula. What is fistula, guys? Fistula is abnormal connection. It is abnormal connection between two structures. And here this fistula will be of which shape? This fistula will be of H-shaped fistula. We call it pure tracheoesophageal fistula. Done, guys? Now, the last one is what, guys? The last one is your esophageal atresia. It is going to have a combination of distal tracheoesophageal fistula. This kind of disorder is the most common tracheoesophageal anomaly. What we are having here? We are having atresia of esophagus and distal tracheoesophageal fistula. If you will do examine this kind of patient, a baby, this baby will have air in stomach, right? Now, give me 2 minutes, guys. Let me go to the washroom. Then we will complete it within two maximum 10 minutes, right? Duodenum and congenital anomalies, that is Meckel's diverticulum. These two things are remaining. Other than that, we have completed everything. So give me just 2 minutes, then we are going to start again, okay? So guys, what are the things you should know about duodenum? In duodenum, it is what, guys? It is your shortest it is widest and most fixed part of your small intestine. Duodenum is the shortest, the widest, and the most fixed part of small intestine. The length of duodenum is around 25 centimeters, and the position is from L1 to L3. So the length is 25 centimeters and the position is from L1 to L3. What else you should know, guys? So this is your this is your C-shaped curve, and this curve encloses your pancreas. This curve is enclosing what? This curve is enclosing pancreas. Can you see here? So this curve is enclosing what, guys? This curve is enclosing pancreas. Done? Now let's talk one by one about the parts. What about the D1 part, guys? D1 part is known as the superior part. The length of this part is about 5 centimeters. This part is most mobile part. सबसे ज़्यादा हिलने वाला part कौन सा? It is the first part of duodenum. Okay, and this part is having ulcers, and it is the most common site for duodenal ulcers. Most common site for duodenal ulcers. Then we are having the second part, that is D2. What about D2, guys? D2 is known as descending part. The length is around 8 centimeters, and in this part what will happen? In this part your common bile duct and main pancreatic duct, they both are going to open. They both are going to open at the level of what, guys? At the level of ampulla of Vater. They both are going to open at the level of ampulla of Vater, right? Now let's talk about the third part. This part is horizontal part and around 10 centimeters long. Which is around 10 centimeters long. This part is my horizontal part and around 10 centimeters long. This part actually is a sandwich between your two arteries. So this part is actually sandwiched between, from front it is your superior mesenteric artery, from behind, from posterior side it is abdominal aorta. In between this part is what, guys? This part is your D3. Then the last part is what, guys? The last part is your D4. And this D4 is what, guys? D4 is your ascending part. How much centimeters it is? It is around 2.5 centimeters long. is around 2.5 centimeters long. Now, the last thing for today, it is what guys? It is your congenital anomalies. What are the congenital anomalies you should know? Uh, the one anomaly which I am going to discuss here is Meckel's diverticulum, guys. It is very, very important. It follows the rules of two. What you should know about this, guys? This Meckel's diverticulum is the most common congenital anomaly of intestine. It is most common congenital anomaly of small intestine. Then guys, this kind of anomaly is following the rule of two. What is the rule of two, guys? In this 2% of the population which is present in the males, the child which is less than 2 years of age, it is present 2 feet above the proximal terminal ileocecal wall, and it is around 2 inches in the length. It is a true diverticulum, and this diverticulum is found where, guys? This diverticulum is found is going to have right iliac fossa pain. Okay. What I am trying to tell you here are the complications of this. What are the complications? So the complications are patient will can have intussusception, intussusception. The patient can have bleeding, and the patient can have volvulus. What are all these three things? We will discuss it later. Okay. Now it is not important. Patient can have intussusception, bleeding, and volvulus. Can you see this thing, guys? This is your Meckel's diverticulum. This Meckel's diverticulum is, guys, a true diverticulum. It is already written here, right? It is a true diverticulum, and it will present with what? It will present with right iliac fossa pain. Last thing which I am going to tell you here is it is always present on anti-mesenteric side. It is always present where, guys? It is always present on anti-mesenteric side. And this is what, guys? This is your mesenteric side. Done. Done for today. Done for all the Viva topics. Everything is done.